Hello and good morning. I am pleased to join you today to share some highlights and updates from the HIV Care Services Unit of the Division of Disease Prevention. 3 weeks ago, VDH participated in our first comprehensive site visit with the Health Resources and Services Administration. As a part of that visit, we highlighted the HIV Care Services Ryan White B Part B program here in Virginia and shared how the program has changed in the 5 years since their last visit. This is one of the slides that we shared during that presentation, which underscores not only how widespread our subrecipients and contractors are throughout Virginia, but also underscores our significant growth in just 5 years. As you can see, we have added 10 new Ryan White Part B providers since 2017, an average of 2 a year. As part of our efforts to support that growth with technical assistance and peer connections, VDH hosts 4 joint prevention and care contractors meetings per year. Our next meeting is March 2nd, and due to continued coronavirus precautions, will be held virtually. Highlights of the proposed agenda include an update on our new medications approved for PrEP, further discussion and guidance about the PROVIDE system, and unified eligibility, and something we call a fiscal boot camp for contractors that will help contractors learn how to complete their Ryan White Part B budget workbooks and work plans, along with other technical assistance related to the fiscal side of program administration. I would also like to highlight another innovation in the way we offer continuous technical assistance, support, and guidance to our contractors through monthly calls. We implemented monthly calls in April of 2021, in part as a more interactive replacement for monthly written reports. Most Ryan White Part B contractors are required to participate in 9 monthly calls per year with their designated services contractor or contract administrator. These calls, which follow a set agenda, facilitate on ongoing collaboration, dialogue, and partnership. Topics covered can include agency successes and challenges, pace of spending analysis, and technical assistance on a particular topic. As we near the end of the grant year, please look for a survey soliciting your feedback regarding these calls. We are continuing to develop protocol and best practices based on evaluation, and we need your feedback to make these calls as meaningful and as effective as possible. Finally, I would like to share the concurrent and upcoming vacancies we have within our unit. The Virginia MAP program will soon list a full-time medication assistant specialist position. Watch for that listing on the Commonwealth's website. Additionally, the Virginia MAP is continuously recruiting for the following contractor roles: medication assistant technicians, care coordinators, and retention coordinators. These positions are open until filled. To apply or for further information, please contact Jasmine Ford via email. In care services, we have a contract services coordinator position we anticipate advertising in the coming weeks, and an open recruitment for a quality management specialist. To apply or for more information, please email Safri Jawara. Please note this position closes February 23rd.
Good morning, I'm Tom Salyer. I'm happy to be here with you all this morning. Today, I'm going to be discussing the intersection of HIV and aging. We will be discussing the layers of living with HIV and aging by taking an in-depth look at 3 essential themes, which include uncertainty, stigma, and resilience. The objective of our discussion, we will be examining the characteristics of uncertainty within aging, and HIV. We examine the double stigma of ageism and HIV, and we will examine the power of resiliency of aging with HIV. In 1981, I was 20 years old and living life as an openly gay man. During this time, the LGBTQ community was at a pivotal point with the fight for equality. Many refused to be invisible and were demanding a place in society. Just a few years later came the whispers of a disease killing gay men, and it had us holding our breath, afraid to exhale, afraid to speak of it. The decade that followed were now filled with despair and loss. At the peak of the AIDS epidemic, the years 1987 through 1996, baby boomers were aged 34 down to 16 years old. AIDS decimated our social networks and shaped our personal and social lives throughout our life course, and now into our later years. AIDS killed more than 300,000 men and women in the USA between these pivotal years. With the AIDS epidemic, we found ourselves out of the closet and thrown into the trenches. It's difficult for me to put into words on what it was like seeing my loved ones and friends and community members get sick and die. I lost count of the number of people I loved and knew who simply just disappeared. Today, nearly all older gay men alive, regardless of their HIV status or when they come out, have been impacted in some way by HIV and AIDS. Many of these men and women were and continue to be HIV, AIDS activists, and or have careers and have played and continue to play a central role in the LGBTQ community's history. The first cases of HIV in women were identified in 1983. And in 1986, the CDC reported that AIDS was disproportionately impacting Blacks, African Americans, and Hispanics, Latino Americans. A generation ago, a list of tips for aging well with AIDS would have seemed like a cruel joke, and it would not have been useful because for many who contracted AIDS, life expectancy was less than a year after the diagnosis. Today, however, people who are HIV positive are living as long as the general population. Today, nearly half of all people living with HIV in the United States are age 50 or older. This is mostly because people are living much longer with HIV thanks to effective antiretroviral therapy, and that's good news. The bad news is research increasingly shows that diseases that typically strike HIV negative people in their 60s and 70s are occurring in people with HIV in their 40s and 50s. These concerns have brought the issue of aging with HIV to center stage. One of the biggest unanswered questions is why is this occurring? Whether it's heart attacks, bone fractures, kidney disease, or certain cancers, the rates of these conditions in HIV positive people are alarming. It's unclear how much HIV contributes to these conditions or how much is explainable by other factors, such as smoking, HIV drugs, and co-infections with other viruses. The increased burden of symptoms such as fatigue, pain, and depression can negatively influence everything from daily functioning to employment to quality of life, dysfunction, and frailty. Beyond in-clinic care, older adults in their mid-50s and 60s with HIV often need services that other older adults get from senior centers, but many don't qualify because services like meals, benefit assistance, recreational activities, and more are only offered to people 65 and older. Even if hubs of programs and resources for older adults do expand their offerings to people in the 50s and early 60s, is that 50-something with HIV going to feel comfortable among a place with mostly people in their 80s? Many of us aren't able to work because of disability, or they've been out of the workforce so long for HIV/AIDS treatment that it's hard to get a job. The question is, how do we take a phenomenon like this and make them more flexible and able to meet the needs of multiple generations? Some of the concerns we have as consumers with aging and HIV are, we have a concern over the threats to continuity of care resulting from shifting health coverage to Medicare and to Medicaid, or changing private health insurance plan. The concern frequently rises to fear and anxiety. Experiencing comorbidity with several non-HIV related health conditions and dealing with the challenges of managing care with multiple doctors and other healthcare providers. The challenges are raised the need for case management services that can help to facilitate medical care. Questions about the impact of HIV on aging, the impact of HIV on non-HIV conditions, notably cardiovascular disease and diabetes, and the impact of aging on HIV. Another thing is polypharmacy issues, including the interaction between HIV medications and medications for non-HIV related conditions. We have concerns over the lack of safe, adequate, and affordable housing, lack of transportation options, concerns over the lack of transportation, and increased need for supportive services, persistence of loneliness and social isolation, heightened concerns about stigma and discrimination, with many of us experience stigma and discrimination, and the need for the lack of geriatric care and the assistance of paying for this service. Double stigma. Ageism has been defined as a negative attitude towards aging based on the belief that aging makes people unattractive, unintelligent, asexual, unemployable, and mentally incompetent. HIV stigma has been defined as prejudice, discounting, discrediting, and discrimination directed at people perceived to have HIV and AIDS. HIV stigma is a multidimensional construct and may be enacted or felt. Enacted stigma refers to individually or collectively applied. When it comes to HIV prevention, the treatment, there's a growing population that has been overlooked, older adults. And implicit ageism is partially responsible for this neglect. The lack of perceived HIV risk in late adulthood among older people themselves, as well as providers and society in general, inhibits investment in education, testing, and pragmatic responses to address HIV in an aging population. Simply put, ageism perpetuates the invisibility of older adults, which renders current medical and social service systems unprepared to respond to the needs of people aging with HIV infection. Previous research has suggested as many as 2/3 of all older Americans with HIV have experienced stigma due not only to the disease, but to their age. This phenomenon may be even more pronounced among gay and bisexual men because of an increased obsession with age and internalized ageism within the gay community. Aging with HIV is difficult because stigma both from HIV infection and from aging creates negative stereotypes of aging, including viewing older people as needy, senile, and less useful than younger people, persist and can be added to the negative stereotypes and overt discrimination of HIV infection. And these stigmas can lead to increased quality of life, increased burden of symptoms such as fatigue, pain, and depression. This negativity influences everything from daily functioning to employment to quality of life. We can all help reduce these negative stereotypes by learning the facts about HIV and aging and respecting this population, fostering hope and empowerment among aging adults with HIV. The combination of stigma due to age, sexual orientation, race, ethnicity, gender identity, and expression, and HIV can lead to a number of negative outcomes specific to this population. Stigma results in social isolation, either through rejection by social network members or self-protective withdrawal, leading to loneliness and ultimately depression. Stigma also makes people reluctant to disclose their HIV status, which could affect their healthcare treatment or prevent them taking precautions to reduce transmission. Social isolation and social support are key social determinants of health, which may have connection with HIV-related stigma and ageism. Stigmatization may also result in healthcare providers not paying attention to the mental health and sexual health of older adults. My experience with stigma has caused me at times to socially isolate myself and not seek out care for support. An example of this took place about 7 years ago. My primary doctor suddenly left and I had to find a new doctor, which is a daunting task when you live in a rural area. There's a shortage of doctors, and especially good doctors and their staff who are compassionate, knowledgeable of the obstacles of living with HIV. At the time, I was in a dark place emotionally. I was experiencing severe depression, and I didn't feel like others, including those in my support system, were actually hearing my pleas for help. So my hope was to find a good doctor and that they would be able to help me. I found a doctor someone recommended to me and went for my first visit. I was with the nurse and she was asking me about my medical history, and I told her that I was HIV positive, and she was shocked that I was so open about discussing it. She then went on to say that she and the other nurses fight over who's going to see the HIV patients because they would rather not see them. As I sat there in that moment, I wanted to disappear. I was emotionally and physically exhausted that day, and I could not respond if I wanted to. Needless to say, I never went back to the doctor and eventually found a good doctor who listened to my needs and found me help dealing with my depression. This is just one example of experiencing stigma and shame. This happens more than you think. It may not be this severe, but it happens. And I believe those of us living with HIV, especially long-term survivors, either stand up and fight it head on, or we hide from it because we're emotionally and physically exhausted, and it takes all of our energy just to keep our heads above the water. And of course, this encounter added to my existing trauma of living with HIV. As a matter of fact, this is my first time sharing this encounter because I felt so much shame about what happened to me that day. And I didn't think anyone would understand or that they would think I was feeling sorry for myself. I can't begin to express the importance of having psychosocial programs in place and the need to engage your consumers especially those who are long-term survivors, because it doesn't take much to cause major setbacks to our overall health and quality of life. Particularly now, because we're living through our second pandemic, and once again, we find ourselves isolated and struggling. It's imperative that providers have programs in place to keep us engaged. Many of you have developed plans to continue your support services, support groups, CABs in place to keep us engaged. Many of you have developed plans to continue these services through virtual platforms. And to those who are still struggling with outreach, let your regional VACAC team work with you on accomplishing this goal. Because of stigma, many consumers can't discuss their struggles or fears with family members. There is a need for a response to address the intersection of HIV and AIDS-related stigma. Decades of HIV research across the world demonstrated priority interventions and several gains in reducing AIDS-related mortality and by keeping the epidemic under control. Despite these gains, older adults living with HIV are constantly excluded from HIV programs. Of importance will be formative research on the experiences, including their experiences of stigma and coping strategies, of older people living with HIV, as well as their sexual health needs. It is often assumed that older people, irrespective of their HIV status, are not sexually active. Therefore, most current health interventions or programs exclude older experiences, including their experience of stigma and coping strategies. Of older people living with HIV, as well as their sexual health needs. Resiliency. In 2001, AIDS turned 40 while the world was immersed in another pandemic. It helped shed light on the tremendous scientific progress we made in understanding, treating, and preventing HIV. A virus that was once a death sentence is now a chronic manageable condition. While there is no cure, with care and treatment as directed by the healthcare provider, people living with HIV can live longer, healthier lives. Now we must all focus our attention on reducing HIV discrimination and disparities and helping break the barriers to equitable care so that those most in need have access to these advancements in prevention and care. Long-term survivors aging with HIV are full of resilience that comes with learning how to cope, connect, and dream again. We're living in an age where we're talking on ending the epidemic and creating an AIDS-free generation. And most survivors and folks aging with HIV feel like we're forgotten, relics of a bygone era who have no right to complain because now we've got good medications. But that attitude denies the trauma that comes with having lived for years in a state of fear, uncertainty, and depression. Of course, the flip side to the challenge of being a long-term survivor is the tremendous coping skills that many have developed over the years. We came together heroically as activists and found strength we didn't know we had. For years, I focused on how many times I was sick or how many people I had lost. And I wasn't focusing on the fact that I always got up. Then I realized I was advocating for myself and eventually my peers. This is resilience. There is no magic bullet for aging well, but eating a nutritious, balanced diet can reduce chronic health conditions and may reduce symptom burden. But there has been less research on this since HIV became a chronic disease. What we know is that limiting alcohol consumption is a critical part of the aging, along with a person's diet, increasing the amount of intensity and frequency of physical activity. And in HIV positive adults, physical activity can improve cardiovascular health. It can reduce distressing symptoms as fatigue and may improve cognitive functioning. We should be training health providers in HIV screening, early diagnosis, and initiation of antiretroviral therapy in older populations and integration of key services. And some of the services should be prevention, education, and outreach targeting older adults, treatment guidelines for older individuals with HIV, funding in line with the aging of the epidemic, engagement of communities, community-based organizations, and social services providers in outreach, mental health, and social support, addressing the needs of special population. A cross-functional approach to long-term medical care for people living with HIV is ideal. Therefore, people aging with HIV should receive ongoing assessment for the following risks: persistent inflammation, neurocognitive function, alcohol and substance abuse, psychosocial status assessed annually, sleep habits, appetite, and suicide violent intent should be assessed during every visit. High-risk individuals should receive annual HBC screenings. Breakthroughs in these areas can lead to new treatment strategies to help not only HIV positive adults age well, but also others who are living with complex chronic conditions. So while we focus on curing HIV, we must also recognize that a cure is likely several decades away. In the meantime, millions of people struggle to age well with HIV. Our HIV brothers and sisters have shown incredible resiliency over the past 36 years. Together, we undoubtedly will find innovative and personalized strategies to overcome these struggles. While working on this presentation, I also was hearing many of my own concerns as an older adult living with HIV. Many times I thought of my challenges in taking 10 plus pills a day, only 2 of which is for my HIV. I also worry about how I'll get long-term care if or when I need it. The presentation gives me a heightened sense of purpose for advocacy work surrounding HIV and aging, and for the importance of calling out the need for new policies and describing those policies and laying out a legislative agenda to achieve the needed policies. Advocating for myself as an older adult living with HIV and aging gives me purpose and power to continue this journey and fight for all of those in this battle, including all of you stakeholders here with us today. Being a part of this today reminded me of the importance of National HIV, AIDS, and Aging Awareness Day. You can appreciate the progress that is enabling people living with HIV aging into our 50s, 60s, 70s, and beyond. You can be aware of the continuing and new challenges that older adults living with HIV are experiencing every day. You can reaffirm your commitment to making sure older adults with HIV are thriving and living our lives with dignity and respect. Again, I'd like to thank you for letting me share with you today.
Karen Ingersoll, PhD, is a licensed clinical psychologist and professor of psychiatry and neurobehavioral sciences at the University of Virginia School of Medicine. She is also the co-developer of the Positive Links Health Intervention for HIV Care, which has been recognized by the CDC. To read more about Dr. Ingersoll's work and accomplishments, please refer to the speaker page. Now we will hear from Dr. Ingersoll to provide some information on the UVA Transgender Health Study.
Hello, everybody. My name is Dr. Karen Ingersoll. I'm a psychologist and a professor at the University of Virginia School of Medicine, and I'm very excited today to share with you some of our progress on our TGNC survey. TGNC stands for This Great New Community, and it's also an acronym for Transgender and Gender Nonconforming. So I'm going to tell you about our progress with UVA and VDH partners in surveying TGNC people across Virginia. So let me tell you a little bit about the context of the survey. We are trying to survey as many transgender people as we can, because transgender people are an important and historically understudied population. And previous surveys of transgender people have typically not included very many non-binary participants in surveys. Something we know about this population is that they may experience different barriers and resource gaps depending on where they live, rural versus urban, as well as their demographics. So things like race, age, gender identity. And often they experience stigma, discrimination, and unfortunately, limited access to high quality healthcare that's trans friendly. There's a lack of providers who are sensitive and well trained in caring for transgender patients. And they also have a higher risk for mental and physical illness. They may include a higher risk for HIV infection, substance use, and other issues. So the goals of our survey were to really learn about the health status and social determinants of health for TGNC people in Virginia, evaluate their access to quality health care, and assess their psychological and behavioral factors that might be related to the increased risk of HIV infection. So this is an update of a survey that was conducted in Virginia in 2004 and 2005. And the way this survey differs from the previous one is that we have updated and added more comprehensive measures in the current survey. So we have way more measures of mental health. We've included the gender nonconforming population, which wasn't really a part of the previous survey sample. And we've also updated terminology to use more modern terms that more TGNC people are using for themselves. So in this study, we defined trans people as those whose gender identity differed from their sex assigned at birth, whereas gender nonconforming people are those who have gender expressions, behaviors, or mannerisms that are either a combination of male and female or something else, and they don't consider themselves male or female. Now, our survey study design was originally a respondent-driven sampling strategy. And we had a lot of hopes for that strategy, but we ran into many problems that made that strategy unfeasible. So instead, with our VDH partners, we modified our survey design so that we're now using a convenience sampling survey design. And our goal is to ascertain and recruit 759 people. And if we're successful, this will be an estimated 2% of the Virginia trans population, estimated just under 38,000 people in Virginia. And at this moment, well, as of the time where this PowerPoint was designed, we had 41.8% of our sample ascertained. So that was 317 enrolled and analyzed as of January 21st. I'm recording this a few weeks later, and so we've actually added some more participants, but I haven't analyzed those yet. So I'll be telling you about our sample of 317 participants. The survey is administered verbally over the phone or in person, and the survey administration is guided by a HIPAA-secured Qualtrics platform. So it's quite automated, but it requires the human touch. Participants are compensated with $50 of a gift card of their choice, and the people we're including are adults, so 18 or older. They have to identify as transgender or gender nonconforming or non-binary. All races are included, and we have English and Spanish speaking interviewers, so we can complete surveys in English and Spanish. People must either live in Virginia or receive health care in Virginia within the past 2 years, and college students can participate if they're going to school in Virginia. Here's some samples of our recruitment materials. We're doing a combination of in-person, flyering, and online advertising through UVA's IRB system. And you can see that we've got a social media post displayed on this screen. We've also got a palm card that we give out at different festivals and fairs and to partners to distribute. So we've used a variety of advertising, and word of mouth as well has generated applicants to date as of January 21st, 2022 of 753 applicants. Here's the study flow. Here's how someone gets into the survey. So first of all, they see one of our advertisements and they contact us by phone or email. The participant may submit an interest form, and once that is received at UVA, we review it. Sometimes they're clearly ineligible or don't leave enough information to judge, and so their participation ends. At that point, we do the remaining surveys. We subject to an eligibility check and an identity check. This happened because early in our process with respondent-driven sampling, people were trying to complete the survey 2 or 3 or 4 times. And so we want to make sure we have unduplicated, unique individuals participating in the survey. So we do a quick identity check where the people who pass go ahead to scheduling, and they get scheduled with one of our high quality, well-trained interviewers. The RA or interviewer then completes the interview as scheduled, sends summary information to UVA, and then UVA submits the payment to the participant. So now I'm going to turn to some of the findings to share with you today of who we have in the survey. And again, this is a small, just a part of our sample. We have a few more than this now, and this represents about 42% of our intended sample. So we're not quite halfway. So gender assigned at birth, sex assigned at birth of our 317 participants, mostly female, and mostly assigned female at birth. Their self-description varies. So we have lots of options for people to describe themselves, or they could pick one of the standard options to describe themselves. So the largest single group at this point is gender non-binary rather, which is 37%, followed by trans men or transgender men, transmasculine, 26%, followed by 18% who identify as transgender women, trans feminine. And smaller sets of other identities are also part of it, including gender nonconforming, 6%, and so on. In terms of race and ethnicity, by a large degree, we have mostly white respondents, followed by multiracial, then Black, then Asian. We do have an increasing number of Latinx participants now that we have our Spanish-speaking colleagues administering the survey. And so we have so far 4% of our sample Latinx. And as you can see on the pie on the right, they come from a number of different countries of origin. In terms of demographics, the average age is 32 with a minimum of 18, and we have people as old as 71, so around 30 years on average. Average annual income is above $10,000 for 75% of our respondents, And about 79% of our respondents have never been homeless, but 21% is a significant minority who have experienced homelessness. Turning to HIV testing, which is one way to prevent the spread of HIV, 67% have had an HIV test, and 98% are not HIV positive, whereas 2% are HIV positive. HIV prevention-wise, looking at PrEP, we see that a very small proportion of our sample has taken PrEP, 4% currently, 3% in the past, meaning that 93% have never used it. So this means only 12 people are currently on PrEP. Fortunately, of those, they find it easy to take their pill every day as prescribed. We'd like to see these numbers bump up. Mental health. This is an aspect that was really not adequately covered in the previous survey in 2004 and 5. So we've started to look at our mental health data. And what you'll see for depression is that the majority of participants, about 95%, have endorsed some level of depression now or in the past. And anxiety is similar. The majority of participants have experienced anxiety. Now, those who've experienced severe symptoms is less common. So 5% severe depression, 9% severe anxiety. The good news is many of these are seeing a mental health provider. And of those seeing a mental health provider now, 78% feel like they really are known as a person. And this is a really good prognostic indicator for the benefit of treatment. Unfortunately, on the flip side, 82% have felt that at some time I needed mental health treatment, but I wasn't receiving it. Turning to substance use, you can see on the pie on the left that alcohol consumption is very common. We do have 5% of people who endorse that they are in recovery now, 6% who've never had alcohol, and the remainder have had some amount of alcohol in their life past year or past 30 days, with the majority answer being, yes, I've had alcohol in the past 30 days. In terms of other kinds of substance use, not including alcohol, but other kinds of drugs, in the past 30 days, about a third of people have used some kind of drugs, 21% never have used them, 32% have used them sometime in their lifetime, and 13% in the past year, but not in the past month. So drug use and alcohol use are common. Turning to suicide, the majority, slight majority, 55% have never attempted suicide. But among the 45% who has attempted suicide, the majority feels like their gender identity or discrimination related to gender identity contributed to that feeling. Now, turning to the issue of abuse. Unfortunately, many of our participants endorse having experienced abuse in their lifetime. So 65% have been sexually touched without consent, and 51% have been physically attacked. So slight majority have been physically attacked, about 2/3 have been sexually touched without consent. Now, you can imagine that healthcare access is an issue of great concern to this population, and especially for TGNC-related hormone treatments, surgeries, et cetera. So ever received any TGNC-related healthcare? 85% said, yes, I've ever received it. But a majority, 54%, said at some time in the past year, I've needed these services, but I could not get them for some reason. Now, a lot of our surveying has happened during the era of COVID-19, and it's possible that some medical care services have been reduced because of the pandemic, but we're not sure that that's what explains this finding. We expect that a majority of trans and gender nonconforming people who might want gender sensitive healthcare have had some difficulty accessing it. Now, during COVID-19, we asked a couple of additional questions beyond those that we had originally planned for the survey when we were designing it pre-pandemic. The majority of our participants have been tested for COVID-19. Only a small minority have tested positive, and the majority has been fully vaccinated. So let me just summarize for a few moments the preliminary findings I've shared with you today. And I'm going to hit just a couple of the highlights that I think are important for us to think about as we plan HIV care, HIV prevention services, and general healthcare services for Virginia. So as I said, we have about 42% of our sample in at this point, and we are finding far more gender nonconforming, gender non-binary people than were assessed in the previous survey in Virginia. So 20 years out, more people are endorsing a gender non-binary and non-conforming identity. We also have, fortunately, a very high level of experience with HIV testing among this population and a very low HIV positive rate. But unfortunately, an area for improvement is to get more people on HIV prevention medications. So we have very few on PrEP at the present time. We also have had fewer Black and Latinx participants than we desire. We have started to supplement the number of Latinx participants by including some Spanish-speaking interviewers, and we have a fully translated Spanish survey. But we would still like to increase those numbers. We're still seeking partnerships with some Black trans serving organizations. We'd love to hear from you if you've got ideas for us about how we can reach more of these participants. Now, the majority of our participants who are in the survey did get some kind of trans-related health services, but half still needed services that they felt they could not get. Finally, we have high rates of substance use, alcohol use, and anxiety and depression. We've also had a relatively high rate of suicide attempts, and not all people are getting the help they need. Some are getting good help, but not all. And lastly, over a third have experienced sexual abuse or assault, and over half have experienced physical assaults. So we're very concerned about these numbers, and we would certainly like to improve healthcare services for trans and gender nonconforming people. So our next steps for the survey, and this is my final slide for today, is we're going to continue recruitment and enroll the remaining about half of the planned sample. So we're about halfway there. We want to expand our recruitment of Black respondents. We want to make sure that we're capturing all the vulnerable subpopulations and can really understand what their needs are. And then as we accrue more and more participants, we're going to be conducting systematic analysis. We want to understand the life experiences and needs of the subsamples, which might differ from identity to identity or from gender and race groupings. We'll be presenting some new data at conferences to raise awareness. We're planning to publish new data to update the field because we believe that this will become one of the larger statewide surveys of trans and gender nonconforming people that's available. And we will continue to work closely with VDH and our other partners to address continuing gaps in appropriate healthcare services, as well as to improve provider training to address gaps and better serve transgender and gender nonconforming people in Virginia. Thank you so much for your time and attention today. Hope you have a great rest of your meeting. And we would love to hear from you at UVA or at VDH. And thanks again.
Afton Bradley is an LGBTQIA+ health expert, currently the care coordinator manager at the Virginia League for Planned Parenthood. He provides cultural competency and health-focused workshops on working with the LGBTQ community to outside organizations and universities. To read more about Afton, please refer to the speaker page. Afton will now speak on the trans health from the clinical perspective.
Hi, everyone. My name is Afton Bradley. I currently work at the Virginia League for Planned Parenthood. I'm a registered nurse, current student to become an FNP, and a social worker as well. So today we're going to be talking about trans health from the clinical perspective. Before we move forward, I always explain that this is such a broad and expansive topic. So we're going to do an overview, but I do encourage everybody to continue their learning after today, because we could go many more directions with any of these topics. So again, just a little bit more about myself. Like I said, I work at the Virginia League for Planned Parenthood. My name is Afton. I use they, them pronouns. I currently work as a registered nurse, but also am a former manager of 2 transgender health programs, both at Planned Parenthood and Health Brigade in Richmond, Virginia. I'm a folks health consultant. I don't have any financial disclosures. And whenever I talk about trans medicine, I do always let people know that we will be discussing off-label use regarding these medications and hormones. So today we're going to try to go through some brief objectives to make sure that we all at least have a basic understanding of what disparities and issues this community faces, as well as making sure we understand a little bit more about what medical transition means and what barriers and opportunities exist for us working in healthcare to improve these experiences and reduce some of the barriers that trans and non-binary individuals and communities face. So why is this so important? Some of you may have seen me do presentations in the past about similar topics. So I tell people this is important, one, because we're still learning and evolving, and there has been a lot of progress that we've seen back from when we really saw at least the United States start doing a lot of this medicine in the 50s and 60s, where we really pathologized this community. We saw treating trans people in this disease-oriented model, which was very harmful and not patient-centered. And we've shifted to an identity-based model today, which means that we're working on affirming people's identities and using the tools and resources we have to help people live authentically. But we still know that there's a lot of discrimination that this community faces, and that there still is a big gap in terms of access to medically necessary care, whether it's related to transition or not. So I tell people it's always important that we practice cultural humility. I prefer humility over competency, because if you're not a part of the community, it's really hard for and impossible, I would say, to be completely 100% competent. But we do need to practice humility and stay up to date through things like today and these workshops and reading, and really focusing on listening to the community and leaders and organizations doing this work to know where this work is shifting and evolving. And because none of us live in a single isolated identity or bubble, it's important to understand the political and social issues that affect this population, because that impacts the healthcare we provide as well. So first, we're just going to do an overview of some of those objectives mentioned. So I tell people we're doing this from the clinical perspective. So I want to make sure we're understanding both sides of that perspective. So what it looks like for the people providing care, and also what it looks like for the community accessing care. So a couple of studies that really highlight this look at what experiences and attitudes and knowledge we're seeing in 2 different disciplines of medicine. And you can see pretty similar results. So when we looked at was okay, and that people should be allowed to decline care for LBT patients if that conflicted with the provider's religious beliefs. And I'm sure anybody who pays attention to politics and news knows that over the last years, we've seen many iterations of this type of discrimination and different laws and policies being debated in different states around the country. When we look at primary care clinicians, we can see that a big issue is that over 75%, so more than 3 out of 4 clinicians have never met a trans person. And I put in parentheses that they were aware of, because I think many people, more so than they know, have interacted with a trans person and may just not be aware of that. But we can see only about half had treated a person that they knew was trans within the last 5 years. And that most people were willing to provide care, but only 69%, so only about 2/3 felt that they were capable of doing so. So with these studies, some key things came out that we need to focus on in our institutions to make sure that we start seeing those statistics shift. So things that we know help increase that willingness to provide care. People who tend to be in a more general practice, like family medicine, tend to report a better willingness to provide this care. Having met a trans person, so that comfortableness, familiarity with the community, caring for patients. And then they also did some different data looking at empathy and bias with providers, so looking at implicit bias and different fears and discrimination. And people who showed an empathy for the community, are more willing to provide care, which I think makes common sense. And then factors that really decreased the willingness to provide care in these studies, we saw that age mattered a lot in terms of the providers and their responses, people who did have those biases when they looked at those metrics, and then not having exposure to the community, so not treating trans patients and being unfamiliar, and even if they did, maybe their staff not having the knowledge of what was necessary to provide good care. So barriers, as I'm thinking most people are probably familiar with, is that we do have a lack of training, whether it comes to either in your education in med school, nursing school, pharmacy, whatever it may be, you're not really getting a lot of this content. And then that exposure piece, if you're not working with the community and not having familiarity with those care guidelines. So, we all want to make sure we're providing evidence-based practice and best care. And so that unfamiliarity with what is current standard protocols can be a big barrier too. So I said some words, and before I say more, I want to make sure that we all have at least a basic understanding of some common language. There are many more terms out there that people may use to describe themselves or their identities, but these are some common language and terminologies that I think will get us all on the same page for the rest of today. So when we're going to talk about sex, we're talking about really how we in our society classify a person as male or female. So often we think of biology when we say sex, but really when we think about that biology, what we use when we assign these to individuals really is based off of more of their external anatomy or their genitalia, right? So what we write on somebody's birth certificate. But we know that sex is way more complicated and diverse than that. And sex itself doesn't live in a binary of just male or female. There are people who are intersex and people who maybe don't meet that definition or been identified as intersex, but do have many characteristics that don't fit exactly what we see when we think of male or female. So that could be from chromosomes to a hormonal imbalance, different variations to different types of internal reproductive organs and secondary sex characteristics. So the things that we develop through puberty. When we think about gender identity, we're thinking about how somebody identifies. So what somebody says is their identity. And expression is how we show our identity or expression to others. So that can be how we look externally. So today I tell people like I have a beard and facial hair and am wearing what we would consider traditional masculine clothes. So that would be my expression that I'm showing the world today. When we use trans or transgender, it's really an umbrella term for anybody whose gender doesn't align exactly with the sex they were assigned at birth. So for myself, I was assigned female at birth, and I do not identify as female, so I identify as a trans person. Transsexual is an older term that we often don't use as much today because it really was focused on that medical aspect of going through different surgeries and medical interventions, but a lot of people still identify as transsexual. And so I tell people that's a term that I wouldn't use when I'm describing somebody else unless that's how that person describes themselves. Cisgender is the term that can be the contrast to transgender. So it's somebody who does identify with the sex assigned to them at birth. So we often don't think of labeling people who are not trans, but it's important that we have terminology that reflects everybody. And so cisgender would be for anybody who is not trans. A transgender or trans man is somebody who is a man who is not assigned male at birth. And then a transgender woman would be a woman who is not assigned female at birth. So sometimes that can confuse people, so I always want to make sure I highlight that. Non-binary and gender nonconforming are different terms that people might use who don't identify as male or female. So they might identify as multiple genders or no gender at all. And there are many more terms that people might use to describe themselves that are referring to a non-binary or gender non-conforming identity. So the most important thing when you're thinking about language is how the person describes themselves, and what language they use is the correct language, and that's the language we should be reflecting. These acronyms are related to surgical interventions. So there's a lot of acronyms we throw out, and there's debate amongst the community and medical professionals about which one is the best one. So I put them all in here because they're all referring to the similar process, but GCS is gender confirmation surgery, GAS is gender affirmation surgery, and SRS is sexual reassignment surgery. So SRS is the more outdated term, but some people may still use it. And the other two are used pretty interchangeably. And this describes the different surgical interventions that somebody might go through as a part of their medical transition. So I've said transition about 20 times, and so I want to make sure we're all on the same page of what that means. So what does it mean when somebody says they're transitioning, or they've transitioned, or they want to transition? And it really depends, because everybody's transition is going to look different, and there isn't a wrong or right way to transition. So it's really whatever steps somebody needs to take to help them feel more like themselves. And that's going to vary from one person to another. So I often like to think of transition taking up big three spaces. So there's social, legal, and medical, and we're going to talk a little bit more about each of those. So when we think about these big three areas that most people think of with transition, so social transition is what we all may do to live and how the community and society perceives ourselves. So this could be somebody coming out as trans or non-binary, so somebody identifying and saying I'm trans. It could be somebody using a new name, using different pronouns. This could be done like on a social media account, maybe at work, maybe just with their friends and family, but taking some sort of step where socially they are identifying as a, with a new name, new gender, new pronouns, things like that. So legal transition is what things people can do through the legal system to also reflect those identities. And so it could be changing your name legally. It could be changing your gender marker on things like your driver's license or your birth certificate. And that process can vary from state to state. Some states make it pretty simple with just paperwork that you can do yourself. Other states do require medical intervention, meaning that somebody might have to have hormone treatment or have different surgeries before they're able to change different documents. And this is something that's constantly growing and evolving through advocacy. So for example, I work in Virginia, and myself and many others have done a lot of work through policy action to help make it easier for people to legally change and transition. And so now in Virginia, you don't have to have any specific surgery or medical intervention to legally update those documents, but there are many states who still might require those too. And that can also vary from country to country too for people outside of the United States. So medical transition, I think, is what people think of the most when they think of the word transition, and that would be medical interventions somebody can do to help align with their identity. And that could be hormone therapy, it could be surgery, and many other things that people can do through medical intervention to help align their identity. And we're going to talk a little bit more in detail about those, so I'm not going to go over the rest of that just yet. So I mentioned pronouns earlier, and I said my pronouns are they and them. So one of the easiest ways we can show respect for all individuals is by using the right pronouns and names to respect each other. So when we are thinking of pronouns, we use them every day. And the picture on the right, I think, helps for people when we say pronouns. It sounds like a foreign concept. So just as an example of how we use those every day. So thinking of like she, her, he, him, they, them, and there are many other pronouns somebody might use as well. And that's why it's always important that we ask. So we want to make sure we're asking somebody's name and pronouns to make sure we're using that correct pronoun every time we refer to them. And pronouns can change and names can change over time. So it's important that we are asking these, when we see people and when they're, checking in for appointments, things like that. We never want to make an assumption about a pronoun. So a lot of people looking at me today would probably assume that I use he, him pronouns, and I do not. And so that's why it's important that we don't make assumptions, because just by looking at somebody visibly, I'm never going to know how they identify and the way that they want me to refer to them as. So when we are collecting pronouns, it's important that we're respecting privacy and confidentiality. So it's important that we're doing this in a way that ensures that. So not asking in front of somebody's partner or family, and because they might not have disclosed to their family or partner their pronouns and how they identify. And so we don't want to unintentionally out somebody because that could be possibly harmful. And in that same way, we don't want to disclose that information without permission. So if somebody has trusted me to tell me their pronouns and to tell me their name and to tell me their identity, I want to make sure before I share that with somebody else that that's something they're okay with me doing. This can be a big issue when if we're referring a patient, right? So maybe that patient's comfortable in our practice and setting being who they are, but they might be nervous and anxious about us referring them to like a specialist, and they may or may not want that specialist to know that they're trans. So we're going to talk about some barriers and discrimination that this community faces. And when we do that, I always like to put it in context of this minority stress framework. So when we think about this framework is used not just for LGBTQIA+ individuals, but also for any individual that does not make up the majority or the part of the community with power and privilege in our societies. So that can obviously vary from society and culture to culture. So when we think about this, what we're saying is, when I go through these statistics in the next slides, that we're not saying that being trans in of itself is what's causing these. It's basically the prejudice, stigma, and discrimination and sources external to the person that contribute to these disparities. So, being trans by itself does not make somebody more at risk for suicidal ideation, for example, but the discrimination and stressors that our outside communities and society put on this community does exacerbate that problem. So the one you can see that I bolded is that 50% of individuals have had to educate their own medical providers. So you can see how that would make accessing healthcare very difficult if 1 in 2 people have to educate their own medical providers about their bodies and their care and what health needs they have, because as we've talked about, there is that lack of training and experience that we know that different health professionals have. We can see that people are still denied medical services. So just being denied to be seen because you are trans. So for example, somebody trying to find a new primary care provider, they tell the person they're trans and on hormones, and the person's like, no, I can't provide that care for you. You're going to have to find somebody different. It's something that I see, unfortunately, too common. We know that this community has disproportionate rates of lower access to healthcare, so being uninsured, and also higher rates of poverty. So, if you don't have insurance and you have lower income, it's going to be more difficult for you to access that necessary and routine care that's very important. So when we talk about mental health, the one that I like to highlight here, and I tell people I always hope changes, but I've been doing similar presentations for over a decade, and unfortunately it still hasn't really moved too much, is when it comes to suicide. So we do know that 40%, so more than 1 in 3 individuals have attempted suicide at some point in their life, which is much higher than the US national rate of the overall population. And we know that there are things that help improve this. We know that access to the types of care we're talking about today, having social support, having family support, so all of those other areas regarding society and discrimination and needing what you need to help align your identity are what we can do to help lower the statistic over time. We also know that intimate partner violence is very high in this community, and also sexual assault. And you can see that, about half of this trans people that were surveyed in this national study had experienced some form of IPV, and about the same had also experienced some form of sexual assault. So something especially particularly important when we're thinking about, people's sexual health and screenings. So when we think about that intimate partner violence, I like to also highlight that what that violence looks like can look a lot different for this community than other communities. So when we think about violence that somebody can face by somebody who's close to them or a loved one, that emotional abuse can also extend to their identity. So blaming their identity, pressuring somebody to be out or to not disclose their identity, The physical abuse that people can face can also be targeted to their identity. So targeting certain parts of their body, like genitals or chest, not allowing healing time after surgeries, denying access to hormones, so not allowing them to take them, throwing away their medications, things like that. And even sexual abuse can look different too, because it can also look where they're using, stereotypes or using gender roles in an abusive and harmful way. So it's very important that we're using those appropriate screening tools and being aware that what abuse can look like in this community can look a lot different than other communities. Isolation is also a big one that we worry about, because often we know that trans people might already be facing isolation due to things like family rejection. And so further isolation can be even more harmful in those settings. So when we think about all of these disparities and we think about this lack of knowledge and lack of training that clinicians have, it can lead to really harmful experiences in healthcare. And so this one study with the quotes on the left side are from direct experiences that people have had. And you can see that often these weren't related to what happened by the time they got to the provider's room, but often that staff and office culture. So trying to use the restroom and having security threatened on them, being asked inappropriate questions that don't relate to the type of anatomy they have. So assuming that somebody, if they have a masculine appearance, is going to automatically have a penis is that second bullet point. Referring to somebody incorrectly, so misgendering them, using the wrong pronouns, and also using that patient or individual as a learning tool is very objectifying. So it's very common for me to hear experiences and myself to have experiences of once you have disclosed that you're trans, having other a spectator, and that can be very harmful and uncomfortable and prevent people from going back and seeking care again. On the right is a little comic strip that kind of highlights this term called Transverse and Arm Syndrome. And what that refers to is when healthcare providers assume that any medical issue somebody is facing is related to them being trans. So assuming that if somebody is having some sort of symptom or side effect, it has to be about the hormones, or somebody comes in for something unrelated, and then the whole conversation turns into their identity and about them being trans. And this is something that is reported very frequently, where somebody might have went in for a possible broken bone, and then the next 30 minutes is spent talking about their transition and what their family members think about it and things like that, instead of addressing the care they need or saying, oh, well, if you're having like increased depression, it must be because you're on hormone therapy, and things like that are some common examples that I've seen kind of play out with that term. So obviously, when we think about all of these things coupled together, this leads to how patients perceive care. And so there is this inherent or innate sort of fear of being turned away, either by having those experiences themselves or hearing about them. Refusal of care. So even if they haven't had that happen to them, they know it's out there, they've heard stories, and maybe they also have been refused care directly. Having to become that teacher or expert. So taking that time away from them being there for their own health and needs, and becoming the teacher and not being able to get the care that they need. Being misgendered. Unfortunately, one statistic I didn't put on those is that the study did also show that a small percentage of people had also reported assault in a healthcare environment or setting. And so the trauma of what that means, and just the innate trauma of having to, kind of go through and explain everything again and tell your story all over again to a new provider every time. So we're going to talk a little bit about medical transition. We're not going to go too deep into this, but I do think it's important for everybody just to have a baseline understanding, so that if you do have somebody, even if it's not in a healthcare setting, maybe just in your personal life, you know a little bit more about what somebody might be going through and what this might look like. So there when we think of transition, we often think of hormones. So there are a couple of different hormones that people may take, or medications that can impact hormones that can help somebody, align their physical body with their identity. So estrogens and anti-androgens, so anti-androgen meaning something that helps suppress testosterone, are very common for people that are trying to transition and have a more feminizing appearance or presentation. So spironolactone is the most common anti-androgen we use in our country, but there's many more too that people can use in different countries, and some other medications that are accessible if you have access to the treatment, but those can also be more expensive. So these are the two most common you'll see, is some form of estrogen and spironolactone. And these are what they can do. So they can help with chest growth, so they can help with breast development. They help overall soften the skin and thin and slow down like body hair and facial hair. And they help with a fat redistribution. So you can kind of see with what parts of the body are highlighted, how that fat distribution can occur. And it also affects fertility and sexual function too. So it can decrease somebody from having erections. It can impact sex drives, but not always in a negative way. But it definitely does decrease sperm production, meaning that it can make somebody infertile. And so that's a big talking and education point that we have with patients before we start them on treatment. And the bottom just kind of goes through those, and what you can see is a timeline. So I tell people these changes are never anything that happens overnight. It does take time, because it's basically like initiating another puberty. And so people often will need to take medications for several months before they really start seeing a lot of those changes. But as you can see, the big changes here that are irreversible, meaning if somebody stopped, what was going to remain and not go away is that chest growth and development, and then possibly that infertility. But everything else, if they stop taking the medication, may start to reverse into where it was beforehand. So often that means that somebody will be on hormone treatment for most of their life. So testosterone would be doing the opposite, right? So helping with more of a masculine appearance. And so we're doing those opposite body changes. So it can cause facial and body hair growth instead of helping decrease it. It will help with a fat redistribution more to a masculine shape. It also leads to clitoral enlargement, and it also deepens somebody's voice. So both hormones on different sides of the spectrum are helping people, achieve the goals they want to the best we can with what we can do in medicine. Testosterone is often done as an injection, which is why I have that picture there, but it also can be taken in different ways too. So in general, hormones are relatively safe. We don't have a ton of data. We're constantly getting more data, which is great. But we know that these are the risks that people can face, but we know that a lot of these risks are pretty minimal, and we don't see too many individuals being affected by them, thankfully. So testosterone, we worry about things like cholesterol, high hemoglobin or hematocrit, and that's your red blood cells, and that can put you at increased risk for blood clots. So that's why we care about that. It can increase risk for sleep apnea, and it can possibly lead to infertility, but we often know that it is possible for people to get pregnant while they're on testosterone. So that's something that we also keep a close eye on too. Estrogen, we worry about the same thing we would worry about if we were putting anybody on estrogen. So birth control has estrogen in it in some forms of it. So same sort of risk. So we worry about the possible risk of having clots and increasing somebody's risk for a stroke. It can affect your blood pressure and your cholesterol, things like that, and possibly fertility. And then spironolactone is a medication that is a diuretic. So diuretics in general can unfortunately make people have to urinate more frequently. And so that's a very common side effect. And it also can affect somebody's potassium, which is hyperkalemia. So it's important that we monitor their potassium levels when they're on it. And because it's a diuretic, you have to have healthy kidneys for it to be used appropriately. So these two types of medications are not things that are used as commonly in our country, but they are becoming more and more common. So I'm not going to talk too deeply about them, but just want to make sure people are aware that they exist. So SERMs are medications that have been used in our country mainly for people after they go through breast cancer, often as a way to replace estrogen because of how they work. So this is something that more and more people are able to start related to medical transition. And it's really awesome because it only targets estrogen in certain parts of your body. So in terms of what somebody's goals are with what sort of changes they want to see, this might be a better option for them because we can be a little bit more targeted in terms of what types of changes we can make happen. And then the gonadotropin releasing hormone agonists, which is a mouthful, are basically hormone blockers. So these are used often in adolescence when we're doing pubertal suppression. So basically they stop both hormones, the testosterone or estrogen, from being used and processed. And so it can be a great way to either stop hormone production along with another hormone so that we can make sure that we're moving in the right direction for the person, or be able to pause puberty to allow for more time until it would be appropriate to start a hormonal option. So if somebody was like 12, for example, you wouldn't want to put them on testosterone or estrogen, but you could stop puberty so that they don't have to go through some of those secondary sex characteristics that can be very harmful and dysphoric for them. So I put this slide up not because we're going to talk about all these surgeries and what they are, because for many of us, we don't need to know, but to highlight that there is not one surgery. Often people think that when we think about surgery, there's this one surgery that somebody is going to go through, or that there's only one surgical option. And this is just to highlight that there are many ways that we can use surgical interventions to help somebody through their transition. And those can be based on their genitalia or based on non-genitalia options. So I just put up this so that people have access to it. And then people who do want to know more about it, there's some resources at the end of this presentation that can help you do a deeper dive. And also people are more than happy to reach out to me if they have specific surgical questions. So when we think about other things that matter, particularly to the type of work we're thinking of, we need to be mindful of what specific concerns we have related to sexual health. I think of cancer screenings because we think of HPV, and that can be attached to sexual health as well, and some other common health concerns we might see. So when we think about sexual health screenings, it's important to keep in mind what we do know and what we don't really have a lot of good evidence on. What we do know is that many LGBTQIA people do not face a high risk of STIs. So we want to make sure that when we are screening people, we're screening people individually based on their risk and not based on a group risk. So for example, we know that there are higher rates of HIV amongst Black trans women. But just because we know that that group statistic exists, it does not mean that every woman, every Black woman who is transgender is going to have higher risk factors. Unfortunately, data is limited. In general, that's an overarching issue. I think when we think about the trans community is that healthcare data is limited because we've often not studied and included the right demographic statistics in a lot of this data. So it's hard for us to know the exact risk that we're talking about. We do know that an STI lifetime risk does seem to be much higher in women who are trans than men who are trans. But as I said, it's very important that when we are assessing risk, that we're basing it on the individual and on current anatomy. And so if we don't know what anatomy somebody has or what anatomy their partners have and how they're using them, it's really impossible for us to know exactly what their risks are and to make sure we're ordering the right type of screening and tools. So I use this to highlight why it's so important we don't make assumptions. So this study looked at risk and types of sexual risk and activities amongst trans people in Canada. And what they found with all of these statistics on the right is that basically nothing was statistically significant, meaning that it was so diverse in terms of the number of sex partners individuals had, the types of sex they were having, the genders of their sex partners, and what if they were having like higher risk behaviors, for example, like receptive anal sex versus oral sex. And so it just really highlights in a data way what we constantly remind people, in that we really can't make assumptions based on what type of sex somebody's having or who they're having sex with just based on somebody's identity alone, because somebody being trans doesn't tell us anything about their sexual identity or orientation. And a couple of examples to kind of highlight that would be if you had a woman who was transgender who was having receptive anal sex with cisgender men, compared to a transgender woman who's having oral and vaginal sex with cisgender women, well, those are completely different risks. And also those are different body sites that I would want to screen and test. And then a transgender man who is having receptive vaginal sex with cisgender men may be at risk for pregnancy, but a transgender man who's not and is having anal and oral sex with cisgender men may have different risks. And so just a couple examples of why it's so important that we're making sure we're taking a good detailed history when we're working with folks. So how do those surgeries that were listed impact STIs in health? So again, it's very important that we make sure we know what's present and what we're screening for. So I always call it taking a organ inventory or an anatomic inventory. So for example, I could have two transgender men in front of me. One could have had a phalloplasty, meaning that they now have a penis, and the other one could still have a vagina. And I need to know what parts are present so I know what risks are there and what type of testing we may be able to do and what we shouldn't do. And then neovagina on the left, so that would be the vagina that's constructed surgically in a transgender woman. And you can see that the STIs that we would screen for are pretty similar to what we would screen for in anybody with a vagina, but there are some conditions related to that surgery that can mimic an STI, so with symptoms. So they use often, they can use different parts of your body, but one common site is to use the skin from the penis and scrotum. And so hair is removed before that, but sometimes the hair growth can still come back. And so that can mean that you might have something like folliculitis or an infection related to that hair follicle that might look like an STI. And so it's important that I know if they've had those surgical interventions, because I might not know just by physically doing an exam, so that I know I'm screening and looking for everything correctly. And then even with surgeries, there's different ways to have them. And so for the right column, a phalloplasty or metoidioplasty are two different surgeries people can have to construct different types of penises through surgery. But you don't always have the vagina removed, and people might still keep their vagina intact, maybe for sexual function. So just because they've had a phalloplasty still doesn't tell me the whole picture of how they're having sex and what types of risk I'm worried about. So I mentioned cervical cancer screening because HPV, the human papillomavirus, as many of us know, is something that can be transmitted sexually. And we know that trans men are much less likely to get routine cervical cancer screening. It could be because of lack of medical knowledge of risk. So we're not really targeting education to this community. They might have dysphoria, meaning that having any sort of pelvic exam can be very traumatizing. And so they might be avoiding it due to that. Or they can't find a provider that they trust and is friendly and knowledgeable of, to go to receive this necessary screening. So just keeping in mind that that's also something, especially in routine care, that we want to keep in mind on, and particularly as well if we're working with people who are living with HIV, making sure that they're getting those really important health maintenance screenings too. So when we think of some other concerns, so I tell people that when we think of just overall general health and those important sort of screenings and health maintenance, that we don't have a lot of evidence in certain areas. And so I just kind of mentioned a couple key important ones. So when we think about people assigned female at birth, the good thing is we don't see any evidence that being on testosterone or anything else is increasing their risk for cancers. And I am highlight that because there's still some antiquated knowledge that sometimes comes through that being on testosterone would increase the risk for some of these cancers, and studies have shown it does not. So that might be a good thing that we are able to, after hearing this, be able to tell somebody to help relieve that anxiety and concern that might be preventing them from taking that step. With test screenings, there isn't really any guidelines to know exactly what to do after somebody has had like top surgery, but in general, we know the risk for cancer is going to be lower because they've removed some of the tissue, but not all. So they should still, communicate with their provider. And that's why it's important we know it's been done so we can make sure that we're doing necessary, exams when the time happens. And for people who were assigned male at birth, so that could be like a transgender woman, we know that hormones create breast growth now. And so it's important that after that breast tissue develops, they're being screened for cancer, just like any woman should be. So both cisgender and transgender women, if the transgender woman has been on hormones for at least 5 years, should be having breast cancer screenings based on standard guidelines. Most are still going to have a prostate, so we're still going to need to do that screening too. And we won't need to do an HPV screening or cervical cancer screening on transgender women, even after a vaginoplasty or, that vagina is constructed, because there's going to be no cervix there. So transgender men still need it if they still have their cervix, but transgender women won't because they will not have a cervix. So I mentioned fertility and reproductive health just to really highlight that we're seeing a growing increase in people who want to expand families and either keep fertility, have their own children in different ways, or adopt and through foster care. And so we just see this growing number of LGBTQIA individuals and families wanting to plan and grow. And so it's important that we're talking to people about, family planning and reproductive health to make sure that we're not a barrier to them being able to explore those options. And it can look, very similar to how anybody would might explore parenthood. So it could be through those assisted treatment options like sperm freezing and egg banking. Those are things we can do before hormones start, so people can have that possibility later. They might use surrogates, they might use like IVF, or can be done through sexual intercourse, or like I said, through adoption and foster care. So making sure that we're not just assuming that because somebody's trans that they are not going to want to, or they are going to want to pursue parenthood in the many different ways parenthood and families can look. So lastly, we just want to go over a couple of quick ways to improve our practices. So the one thing that all of us can have a play in, regardless of whether we're the healthcare provider, an advocate, a front desk staff, anybody who is inside of these organizations can help create a welcoming environment. So we always want to make sure we're aware of our own comfort levels and biases. Like we saw in that study, there are still a lot of biases that people may have. And so we have to learn how we're going to overcome those and what that means for when we are working with this community, and what we need to learn to either unpack or work through to make sure that we're staying a nurturing environment. We want to be open to learning because this is always evolving and changing. And if we are already in that space, we want to make sure that we are getting on a resource list. So we want to make sure that people know they can come to us, because often that's the hardest part, is people don't know where they can go. And if there's nothing online or on social media or on our website that tells somebody this is a safe, affirming place, they may not trust us. You want to advocate for changes to how we collect data. So are you collecting somebody's pronouns? Are you collecting the names they use? Are we taking that anatomic inventory? Like, do we have spaces when we're doing exams to document these types of surgeries and what organs may be present? Providing neutral bathrooms. So when I say neutral, I mean gender neutral bathrooms, and knowing where to refer patients for culturally competent care. So maybe you are providing HIV treatment and you don't do hormones, but a patient asks about it. So knowing where to send somebody if you don't provide that care directly. And really important, and came through in those studies and in many studies, is to train all of our staff. So we often focus on the providers and nurses, but forget about our front desk and administration and people answering the phones. And those are the first interactions people have and often can be the most important. So we want to make sure if we are training that we're including everybody. So when we think about what patient-centered care looks like for this community, so we want to make sure we're building rapport. So I always tell people when we're starting somebody on hormones, if I've never met this patient, I'm not going to jump into necessarily talking about cervical cancer screening and genital exams unless the person is comfortable with that. We'll wait until I've developed a good relationship with them first. We want to only ask the questions we need to know, so avoiding asking questions out of curiosity. So if I'm treating somebody because I think they might have strep throat, I don't really need to know what their genitalia looks like. Thinking about using neutral words, which is what these tables have for you. So just some examples of ways we can start shifting our language to using a more general term that could be used for anybody, so that we're not adding to that harm or dysphoria that somebody may have. Doing that organ inventory, like I've mentioned, and knowing when to use a support person or referral. As I say, don't fake what you don't know. People are going to respond better if you're just honest with them and say, I'm not familiar with that term, or I haven't worked with somebody that's had X, Y, or Z. So I'm going to reach out and, get some help or refer you, and making sure that we're not, just dismissing those concerns. So the last thing I wanted to go over was just this really great article that I encourage everybody to read. This person is a trans person and works in healthcare, so similar to myself. And I thought this really summarized in a really nice, short way what professionals should be paying attention to when we think about this community. Understanding that transgender health means understanding the risk faced by this community. So we talked about discrimination. We didn't mention violence in a specific way, but we do know that especially transgender women of color are disproportionately affected by violence, and often that violence can lead to death and fatality. And so knowing those dangers, knowing that you can still be discriminated in a lot of jobs, knowing you don't have access to care, that IPV we mentioned, all those things are so important. That humility is really important too. So like I said, not faking what you don't know. So you might say, like, if you've never worked with a trans person, that's okay. And you can be honest about that and say, I've never worked with somebody who is trans, but I'm willing to learn. And that way they can also make that informed decision to stay with you too. The other kind of key lessons I wanted to highlight, so transgender patients are not all alike. So we talked about transition and how that can look different from person to person. So not assuming that just because somebody is trans, they want to be on hormones or that they want certain surgeries, that everybody's story is going to look different. And we need to learn from the person themselves what a transition looks like for them. And that's kind of what lesson 4 also attributes to. So making sure too that we're not implying our own perceptions of what men and women are to our patients. So not, if somebody says they're a transgender woman, not assuming that they have to present in a certain way or that they have to do certain things. So really unpacking what we think of it means to be a man or a woman, and not putting those biases on our patients when they present to us. Lesson 6 we've talked about in terms of pronouns, so making sure we're using the right ones and apologizing. And really lesson 7 is really important, and often I think is the most uncomfortable, and that's really taking leadership when it comes to hearing demeaning references. So that could be hearing gossip in the office, it could be hearing somebody commenting about somebody's appearance or using slang or the wrong pronouns, and really taking that ownership to be the advocate and leader, and challenging those and making sure that you're creating an office culture that is safe for everybody, and knowing what is acceptable and is not. Lesson 8 is related to what we kind of talked about with that Transverse and Arm Syndrome in some ways, and also that outing piece. So, somebody being trans might not be relevant to the specific clinical encounter they're coming into, but we want to make sure that we are documenting in a way that is respectful and reflecting that person, and also not outing them accidentally. So in somebody's health record, you might have used the right pronouns the whole entire time, but if part of your visit note has she in it, and then the other half of the visit note has he, which I see frequently, that also is not respectful, and people have access to their own records, so they're going to see that. So really thinking that it's not just when you're talking to the person, but when you're talking to other colleagues about the person, and in our documentation that everything is reflecting who they are. And then the last one I like to highlight is the last lesson, that that being literate in transgender health and being practicing that cultural humility requires ongoing education and training. So I'm very thankful that all of you are listening today, but know that we have just scratched the surface, and that some of the things I said today might change in the next 3 months or 2 years as we constantly grow and evolve. And so it's important that we always stay on top of current practice, and making sure that we're not, falling into those antiquated, beliefs and antiquated terms as things evolve. And there are lots of listservs that can really help too in terms of staying up to date. So these are some resources for everybody that are going to help with some of that ongoing education. So there are some resources that have great guides. The one that I highlight on here that I think is the most helpful is the National LGBTQIA+ Health Education Center in the middle. They have webinars you can get on a listserv, and all those webinars are archived, meaning that we can listen to them on our own time when we have that time, because we all have very busy lives and schedules. And so I love it because it's not requiring you to be at a specific place at a specific time. And so you can really do the learning when it is feasible for you. So I just wanted to thank everybody, and now we'll answer some questions.
All right. Good morning, everyone. Thank you so much for the presentation for Dr. Ingersoll and Afton. And now we will kick things off with some questions and answers. So from your study and gathered experience, what key takeaways would you offer to providers new to transgender health?
So it looks like Dr. Ingersoll might not be participating in the Q&A, so I won't be able to answer that since I know that that was their study. So.
Okay, for the second part, it was for your gathered experience. So do you have anything that, I guess, that you've experienced along the way, that you would maybe offer to providers that are new to transgender health? Like, what is, some of the notable items that they could make note of?
Mm-hmm. I mean, I think that some of the most important kind of key takeaways to new providers when it comes to this line of care is to really understand that first and foremost, that with what we've been taught and learned through our education, that it's a lot of unlearning in terms of even just the day-to-day language we use and how we compartmentalize different types of care and disciplines. And so really taking that time to get to know the community. For me, I'm familiar with the study that was presented earlier too. And just in the studies that I identified too, one of the biggest gaps is that people don't know this community. So really taking that initiative and space to find ways to engage with the community outside of your healthcare setting, because we can always provide more holistic care by really learning and talking to people that cannot often be met in like a 10-minute encounter. And then seeking really some of those resources that I mentioned at the end of my presentation, because a lot of this is not information that you are going to probably get in a lot of learning spaces. And so you often have to kind of seek out and advocate that in your workplaces that they do some continuing education and in-service learning opportunities that are specific to the type of care you do, because this often does take a lot of onus on us to reach out and learn, because it's often not information that's brought to us directly.
Thank you for that. And I also just want to remind everyone that the slides are going to be available at the bottom of the day 2 evaluation. So it was a lot of great information to take in, but the slides will be available after you complete your day 2 evaluation. Okay, so What education do you feel is missing from provider training, specifically for doctors, nurses, nurse practitioners, and physician assistants?
For me, I think it really is the absence of talking about this community. Myself, so I'm finishing up my nurse practitioner education in May, and I went to nursing school and social work and work with a lot of doctors and PAs. And when you think about the education that we've gotten, you might have gotten like a quick like one lecture or maybe a brief series that talked about these identities, but we don't include these identities in the day-to-day conversations and learning content. An example for that to me is that we do a whole, often most of these disciplines, you're going to do a whole breakout or a whole course or a whole, internship or residency related to certain specialties like gynecology, for example. And not once during that entire experience may you learn about, well, what does this care look like for trans and non-binary and queer bodies? And so I think it's trying to find ways in an educational platform to not just have like a one-off, like, oh, and don't forget about these people, but to really make sure the content is always thinking about this community, and it's not an addition, but that it's just a revolving part of that course in education. And I know that there is a university that is attempting to do that with a research project, and I'm excited to hear that, because if you spend 4 years, 10 years, 15 years in school and education, and you got an hour to learn about trans people, but the rest of your conversations were all in a very binary, cis, heterocentric way, then it's really hard to then practice that inclusivity when you leave and go into practice.
Wonderful. Thank you for that. Okay, so we have a question about breastfeeding. Can a trans man who has not had top surgery be able to breastfeed if they have had a baby? And what about a trans man who has had top surgery?
So that's a great question. And for part of it, the answer is it depends. Both of them depend. So if a trans man has not had top surgery, they definitely would be able to breastfeed in the same way that any person, after pregnancy would be able to feed. The only thing that would be important to consider is their hormone use. So during pregnancy, somebody would stop taking testosterone because testosterone is what's called teratogenic, meaning that it's not safe to take during pregnancy. So they would need to, coordinate with their providers in terms of like what their plan was to resume hormone therapy. But I've worked with several individuals who fall into this category and have successfully fed their new infants, and it's been wonderful. And typically testosterone use won't impact that ability, but it can vary from person to person. As far as top surgery goes, that's a pretty loaded question, only because there's a lot of different layers to top surgery. So there's a lot of different options in terms of how that surgery is complete, meaning that some options would leave the glands and nipples intact, and others require grafting and closing of ducts. And so depending on the specific type of surgery that was performed would kind of impact that ability. So often for many people, it's probably not going to be an option if they've had what most people think of as like a traditional mastectomy for top surgery, but it can be a possibility. Often too, there are really wonderful devices where even if somebody can't stimulate and produce their own milk, that will allow them to really replicate that process by using like a donor's milk or a spouse's milk, so that they're able to use a device to be able to hold the infant and mimic that feeding to develop that bond. And so there's lots of great stuff out there. I'm blanking on the name of the person, but there is a wonderful trans guy from Canada who developed a whole resource and webpage dedicated to these specific issues regarding like pregnancy and trans men. So there's definitely a lot of good content out there. And if folks want that afterwards, I'm happy to send that out. I think it's called Milk Junkies. That's what it is. So if you Google Milk Junkies, it will provide you some really great information and resources, especially if you're working with people who are trying to explore those options.
Wonderful, thank you. Can you talk a little bit more about the importance of language, specifically around the difference between saying people born male, female, versus saying people assigned male or female at birth, and any other subtle but vital language tips?
Yeah, so it's really important when we're thinking about language, thinking about kind of the context and the sort of unconscious biases that might come up when we think about ways that we use terms. So when we say somebody, a person was born male, instead of saying they were assigned male, for example, that trans person may have, I consider that person, if they're identifying or they say they're a man, that they've always been a man. And by saying they were born something different, or by saying they were born female, then I'm erasing that person's existence and saying, well, you were born this and now you're this, when that tends to put an emphasis on you must go through certain transitions to be the person you are. And so for many trans people, they're going to tell you, well, I've always been a woman, I've always been a man. And so by saying somebody was born male or born female when that's not their gender, it really just reinforces that static notion. The reason we say assigned as well is because you really truly are, all of us are assigned a gender at birth. We're assigned the sex at birth. And as I kind of mentioned very briefly in my presentation, we're basing this off only what we can externally see and visualize. And there are many people who, if we spent the thousands of dollars it would take to look at everybody's chromosomal makeup, everybody's hormones, everybody's secondary sex characteristics, a lot of people don't really fall into that traditional, binary of male and female based on stereotypes of what we have come to believe, for example, like XXXY chromosomes, or that, only men going through puberty are going to develop facial hair. Well, many women going through puberty also have facial hair, and there are different health conditions that can lead to that too. And that's also just sometimes somebody's natural, presentation and body. And so that's kind of the big reasons for using that specific question. I think in terms of the subtlety of language tips, what I always like to encourage is that language is always evolving, not just for this community, but for all communities. And as we grow and evolve, terms that were once acceptable become antiquated and outdated, and often can become offensive. And so we need to consistently just listen to the people that are parts of those communities, and they really should be guiding the language that we use, and understanding that we're all going to learn and evolve and make mistakes along the way. And so that's, just acknowledging that and really apologizing, and not coming across as I was learned this, and so I know this is the right way, especially if it is a person from the community telling you, this is the language I use. Because even though I might have said in my presentation, transsexual is an old, outdated term, you might encounter a trans person who says, I'm a transsexual, and I'm not going to invalidate that person by saying, no, you're not, because they are, but I might not use that term on a day-to-day basis. And so language is tricky. It's often a paradigm of moving between back and forth. And so just staying up to date. And that's why I mentioned what I said at the end, that, in 3 months, things will be different, because honestly, in 3 months, there's probably going to be at least 100 new terms out there that people may use to describe themselves. So
Thank you for that. All right. And then a comment, hoping to put together a training for our providers to qualify them as a LGBTQIA+ certified. What top 3 areas would you like to see addressed in training?
So that's hard to answer, I think, without knowing a lot more details about what types of practice we're talking about and things like that. What I like, certification is tricky, I think, when it comes to this, because there aren't, for a lot of things in healthcare, I can go through these formal training processes, I can do these workshops and get a certification, but there isn't one for this. I think specifically for trans medicine, like if somebody is looking to prescribe hormones, things like that, I think they do need to look into WPATH and their certification process, which is newer and requires you attending different workshops through them. I think as far as thinking of three really just quick areas that would be important that need to be there. I think really breaking down language, terminology, understanding differences of sex and gender is definitely like one area that absolutely needs to be there. I think talking about just trans health as a whole, because often that is the gap where a lot of people face. And so, for example, sorry, I think my computer is making all these like beeps and I'm trying to get rid of them. I think focusing a little bit on that, especially like if you were going to be in a reproductive health, like how does hormones impact that? Primary care, how does that impact that? So really, whatever the specialty is, like how does somebody going through a medical transition impact what they would need to know in the day-to-day care? And then just thinking about ways that a lot of biases infiltrate all of our care, even to the basic assumptions of like providers seeing a woman and automatically asking about a husband instead of asking about partners and how they're having sex and interacting, and maybe barriers related to like myths regarding like cancer screenings. For example, a lot of queer, bisexual, and lesbian women are not as likely to get pap smears either, because there has been this understanding that you don't have the same risk as a woman who is only having sex with those men. So those are some ideas, but it's a pretty it's a lofty undertaking, and I'm glad you're doing it. And definitely, if you want to talk more independently, I'm happy to talk to you more about making sure if there's any other areas you are trying to knock out.
Thank you. And how do you counsel the health risks of smoking for patients on high-dose hormone therapy?
So I personally like to practice from a harm reduction approach and informed consent model. So for me, it's always what is possible for this patient, not that you can't do something. So first and foremost, I can counsel them to make sure they understand the risk, because a lot of people may not be aware of the risk of smoking for hormone therapy in general, whether it's high or low dose. And so for patients, especially on estrogen, really making sure that they understand, just like I would if somebody was going on a estrogen-based birth control, that this can increase your risk of developing blood clots, and these blood clots could become fatal and life-threatening, and that there's a lot of resources available that we can help both with your smoking cessation and in the ways we can prescribe hormones that can help you achieve both goals, but that unless we start seeing a decrease in your tobacco use, some of our options may be limited. So for example, for certain patients, whether it's smoking or other risk factors, maybe estrogen patches are the only option that is safe to prescribe, and we can't think about oral options because of the risk. And so making sure we're trying to figure out a way to balance like expectations and ensuring that they're able to also participate in that conversation. I think, if we're talking about smoking other substances, there's not a lot of evidence out there to really show harm. And so that's a different kind of conversation. For testosterone, we don't see as carried a risk, but there still is a risk with tobacco use and high-dose hormone therapy for there too, especially because of the implications on hematocrit and hemoglobin levels. But it's just making sure they understand the true risk. And often what I find is that often people initiating hormone therapy that are smoking, they often want to continue to increase their doses and see different changes, and that smoking and exchange of trying to change doses can be a good conversation to kind of guide them. And I see a lot of people stop smoking because they want to go on high-dose hormone therapy. So just keeping the door open and realizing, just as we know for anybody that we're talking about smoking use for, that that's often not a one-time encounter, and just really ensuring that we're trying to minimize harm, but understanding what harm exists if we stop hormones as well, because that's also not a zero-sum game. Stopping hormones can be a very detrimental thing to their health, not always necessarily from a physical perspective, but definitely from a mental health and safety concern. So.
Thank you. And then we have one final question. How can we, organizations and providers, help underserved and underinsured individuals that want to start the transformation and then it has surgery and do not have financial support for it?
So I think that one thing we can do is, depending on the types of organizations we have, for example, I worked at many nonprofits, and we have explored like grant opportunities and funding drives that we have been successful in to help raise funds for people so they can apply for scholarships. Another organization I know worked with some local banks in their state to develop scholarships and loan funds for people to be able to access surgeries. So getting creative to look at what financial resources are out there and how you can partner with those financial institutions is one area to explore. Understanding that Medicaid, so myself and some other colleagues helped advocate with Virginia Medicaid boards of medicine to finally get certain surgeries approved through Medicaid, and that's exciting, and that's something that other healthcare providers can do too. So advocating from a legislative perspective, especially to make sure that Medicaid and Medicare are continuing to provide these services or starting to provide them if they don't, because that can help. And unfortunately, there are going to still be gaps when we think of healthcare being delivered in this capitalist model that we live in. But I think trying to use those sorts of resources can be very helpful. And, there's been a scholarship that's been available nationwide for surgery that awards 2 people every year for over 20 years. And it would be lovely to start seeing more of those. So trying to see, do we have maybe donors, board members, just very, people who are well connected in a wealth status who might be able to sponsor and start working with our teams for some of these. And so that's really where you start looking, I think, higher up in administrative levels of organizations and demonstrating why this is so important, and really just continuing to advocate to create space for that. There definitely are some successful models, but it definitely is not enough to serve the number of people that still are going to be gapped by not having access to those services.
Thank you so much. We did have a comment from Jihad that says, excellent presentation, Afton, thank you. And I echo that as well. Thank you so much for a great presentation and answering all of these questions. Again, their information will be available in the slides. We are now getting ready to take a lunch break. And so we will resume our breakout sessions at 12. Thank you.